Okay, I'm gonna just share my screen real quick and give a quick intro while people trickle in before handing it over to Dr. Strickland. Can you guys see my screen?
Yep.
Okay, so welcome if you're here for the first time with GOWME to our Wilderness Medicine Education Lecture Series. Our mission is to create an educational platform for interested students and healthcare professionals to explore and interact with wilderness and emergency medicine. We showcase the diverse spheres in which physicians and healthcare professionals can make an impact and inspire others to think abstractly about the ways in which we can utilize our careers in healthcare and medicine. Our goal is to create an international community of wilderness medicine enthusiasts and experts committed to promoting a diverse and culturally competent environment. For those of you who are here for the first time, you can scan this QR code with your phone to join our mailing list. We offer biweekly lectures along with some other opportunities as well. We do a fellowship showcase every year, and additionally, we usually have certificate courses, sometimes giveaways, and other opportunities. You can follow us on Instagram and YouTube as well. Here are just some of our current board members. And tonight we will be hearing from Dr. Brian Strickland. He's an emergency medicine physician at Massachusetts General Hospital and a space medicine fellow with the MGH SPEAR program. He trained in emergency medicine at the University of Chicago and completed his wilderness medicine fellowship at MGH. His work spans academic emergency departments and remote settings, including the Aleutian Islands, rural Alaska, the Northern Mariana Islands, and Nepal's Khumbu Valley with the Himalayan Rescue Association. His interests focus on high altitude and extreme environmental medicine, respiratory physiology, and applying medical technologies in resource limited settings. Outside of medicine, he enjoys skiing, diving, and mountain biking. I will hand it over to Dr. Strickland.
All right. Thank you so much. So yeah, thanks for coming, everybody. I know it's a little later on Monday evening, but so I have put together some slides just about my experience working as a physician in the Khumbu Valley with the Himalayan Rescue Association. Mostly just pictures here, just going light as possible on the text. I know you guys are all very busy and spend a lot of time in slideshows, so hopefully this will be relaxing and fun. And let me just go ahead and share my screen here. All right, you see that okay? Um,
Yeah.
so my information is here on the bottom left. I'll show my contact email a little later if anybody has any questions. But yeah, this presentation is called Healthcare in the Khumbu Valley. Really quickly, disclosures. I have no relevant financial disclosures. I'm going to talk about the Himalayan Rescue Association, but I do not work directly for them. I'm a volunteer. So all my opinions and experiences are my own and not that of the HRA. And then just lastly, there are some patient care photos that are included in here. And all the patients and any individuals that are here have all given specific permission for their photos and their content to be used. But I appreciate nobody using it outside of the setting. So just really quickly about me, show just a quick slide about my bio. I'm an emergency medicine physician who did in 2019, 2020, a fellowship in wilderness medicine. That involved me working in the Khumbu Valley with the Himalayan Rescue Association. And that's a relationship I've kept up since then. Um, I also do some high altitude medicine, formerly working in the mountains in Colorado, and as well as some small islands, notably the more of a tropical island setting in the Northern Mariana Islands, specifically Saipan and Rota, and then also some of the Aleutian Islands, which are very remote Alaskan islands. Um, Recently, I've moved back to Massachusetts General Hospital, where I'm focusing specifically on space medicine. applying a lot of the principles that we classically associated with wilderness medicine to manned spaceflight. And so that has been a really interesting new chapter. And if anybody's interested in that, please reach out sometime, and I'd love to chat more about it. But today we're going to be talking about specifically about wilderness medicine and specifically high altitude care in a very remote setting. Just quick objectives. What this is going to be divided up into, I'd say, like 5 major sections. First one being about geography and really just the environment. That's really important to understand. Wilderness medicine is a field that's defined by how our environment affects human healthcare, and not just providing healthcare, but also the conditions themselves. So it's very important to understand that very at the beginning. We'll talk about the Himalayan Rescue Association, its history and what it does in the Khumbu Valley. Many of you will know a lot about some of the altitude-related illnesses such as AMS, HAPE, and HACE. But for those who don't, we'll do a quick touch on those. Talk about some of the other environmental conditions that are found in the Khumbu Valley in very high altitude settings. And then we'll talk about, lastly, some of the emerging challenges and needs in those settings. So first, we'll go with the geography and its challenges. So I realize probably some of the people here listening have done the hike to Everest Base Camp. This is a hike or trek that typically takes about 10 days and starts classically in Lukla, where you can start at a lower town in Geary, and ends at Everest Base Camp, going from 9,000 feet to about 17,500, where the big rock out in front of Everest Base Camp sits. That can be done in around 10 days of hiking. And most people that are, good hikers could probably do that in much less. It is only 77 miles total hiking. However, the reason why we do it over 10 days is not the distance, but it's the elevation gain that's associated with that. And we want to avoid getting an altitude-related illness by climbing very slowly. Actually, at Everest Base Camp themselves, there's about 500 climbers that are there to climb the mountain every year, depending on how many permits the Nepali government issues. But the trekking season, or the trekker population is much, much bigger. These are people who are just simply doing the hike to Everest Base Camp. And that's as many as 50,000 trekkers per season, with 2 seasons per year. And this is just a map of what this looks like. Now, where is Mount Everest? Where is this region? We have a picture of Kathmandu here in the middle. Everest is actually very close by. It's only about a 30-minute flight from here to Lukla. This is just a video showing what that looks like, starting at Kathmandu at around 4,000 feet in elevation. Take a flight to this town of Lukla, known as the most dangerous airport in the world. We begin our trek, which actually starts by going down to Phakeng. We usually spend our first night. We hike along the river, going further all the way up to Namche Bazaar at around 11,000 feet. Sometimes we'll actually spend the night at Tengboche, or we can pass that, but we'll continue on to further up the valley to the town of Feriche, which is where the first HRA clinic and main clinic is located. Bingoche is over there on the right, around 14,200 feet. Then we go up to Lobache, which is around 16,000 feet in elevation. Gorak Shep. Gorak Shep is typically where people who are visiting Everest Base Camp stay overnight, because you're not allowed to stay at Everest Base Camp unless they're a climber. And then we finally arrived here at Everest Base Camp here at the foot of the Khumbu Icefall. Those of you that are familiar with Mount Everest or the climb will know a little bit about this, and it's the dangerous trek up the Khumbu Icefall is the first segment of the Everest climb. All of these environments, as you can see from there, we go through a number of different environments, and they all have their very specific challenges and health hazards. Kathmandu is a crazy busy city with traffic that doesn't seem to follow any specific rules. You can see as 2 of our other volunteers, and you see them, they're caught out in the middle of the road. The plane that you take from Kathmandu to Lukla is not exactly reassuring for any people that have a fear of flying. This is actually a video that I took of the, oh, this looks like it's showing correctly. This is me zooming in on the cockpit. There's a warning saying that there's a terrain ahead. So it's this is the airport that you fly into, and this is the local airport, which is known as the most dangerous airport in the world. This is literally the runway, which essentially just when planes are taking off, they will take off. They'll start here and literally just drive right off the edge of a cliff. And so there's a number of accidents that happen here, but it's easily the most dangerous part of the trip. And continuing upwards, we go through just a number of different climate zones and a number of different environments. The climb starts in almost kind of a very lush and almost tropical area. This is the town of Namche here, going across bridges that are suspended, hundreds of feet above the river below. This is actually the Hillary Bridge and what that looks like. I don't remember the exact elevation of this bridge, but can be it's a very interesting time crossing this. Notably, there's no way to drive a vehicle. Well, it may be possible to push like a small cart, and there are yaks that cross these bridges. There's no way to drive a car or even a small motorbike or anything from Lukla up. So all of the transit in this area is done on foot. But it's a very beautiful area. This is myself with one of the volunteers at Everest ER, and then on the right, Dinosaur, who is our clinic guide. You can see as the environment starts to change as we go higher. This is above the town of Namche. Looking up towards Everest, this is actually the first view of Everest that you get along this trek. And it's just extraordinarily beautiful. Once you get to the town of Feriche, you can see that it looks much different, much more arid. This is an elevation around 14 to 15,000 feet. And we can actually see Feriche down here. This little town. Going even higher, this is a view from Lobiche. Start to see the absence of really any plant material. It's probably pretty hard for you to see at home, but this little tiny subtle trail is actually the trail that we walk along the glacier as we approach Everest Base Camp. And this is that first main view of base camp, around 17,500 feet. So there's really nothing growing up here. The base camp in spring season is scattered across, I think it's a couple miles. It takes about an hour to walk from one end to the other, with a pretty big elevation gain as well. And this is the view actually from the Himalayan Rescue Association's Everest DR, just taken right out front of the Khumbu icefall here. This point over here on the left is actually the main cramp-on point where all the climbers start their voyage to like actually summit Everest. So it's very cool to be up there, and we can see that if you do the trek through the Khumbu Valley, if you're anybody that's living in this area, you're going to encounter quite a bit of different climate zones as you ascend up to just the point where we start climbing Everest, not including Everest itself. So we'll talk about the Himalayan Rescue Association. I'm going to pause if anybody has any questions. Feel free to ask anything that comes up, but I'll pause at every one of these little objectives. Anybody have any questions? Well, hearing none, we'll continue. So the Himalayan Rescue Association is an organization that was started in the 1970s by a group of physicians traveling from Tokyo Medical College. While Everest had been summited many years prior, they realized that this was an area where there were no healthcare resources, either for trekkers or any of the local Sherpa population that were living and working in this region, and noted there were a large number of people that were experiencing altitude-related illness. And so started a clinic, which later became the Himalayan Rescue Association, that was incorporated locally. This is the office located in Kathmandu. This is when you get off the plane. Your first stop here is at the main office to sign all your documentation. The HRA is a organization that has both local Nepali workers and volunteers. But every clinic also gets at least one foreign physician volunteer. This is this is actually in 2024, which is my second season going to work for the Himalayan Rescue Association. There are three clinics that are located. There's the one in Feriche, there's the Everest Base Camp, Everest ER clinic, which we'll show pictures of. And then these two gentlemen here on the left were Australian physicians who are going to work in the town of Manang, which is located on the Annapurna circuit in a different part of Nepal. So this is the kind of the crew that ascended up to the Khumbu, and notably Everest ER, as well as the Feriche Clinic. These are the two clinics work very closely together. This is what the old Feriche Clinic looked like this is my first season working for them. An old stone building that was built again in the 1970s. This has actually been modernized to look much nicer and has quite a bit more equipment than what we would have at Everest Base Camp. The thinking being that this is where the more definitive care and the sicker patients go, where we have solar panels that and large batteries that can power medical equipment. And although there's no heat in this building, there's at least a little bit of a more of a rigid structure that's able to provide more insulation and protection from the elements. It's also at a slightly lower elevation, which can be helpful for our patients that are experiencing altitude-related illness like cave and haze at a higher elevation. The most important thing to do is to descend. So if anybody gets that at Everest Base Camp, we can quickly bring them down to a lower elevation where they can recover here. Meanwhile, Everest ER is not a permanent structure. There are no permanent structures that exist at Everest Base Camp because it's actually sitting, although it looks like rocks, it's actually sitting on a glacier. So everything is actually moving. This is the Everest ER tent, and you can see, although it looks like it's on rocks, this is actually all ice. And typically, after 2 months, all of the tents and everything is actually falling down as the glacier starts to slide down the mountain. So we can't have any actual permanent structures at Everest Base Camp. That's why we do that in Feriche. And this is just a map kind of showing where those locations are. Feriche down here, again at 14,200 feet, is around, depending on your how acclimatized you are, can be anywhere from a 4 to 8 hour hike. Typically, this is done over 2 days for people that are doing the trek. Yeah, my record was walking back from Everest Base Camp to Feriche in about 2.5 hours. So very close, only a few miles away, but separated by pretty significant altitude and very different level of resources. Now at the Feriche Clinic, we are able to do a little bit more, I wouldn't call it definitive care, but we do have a machine that's able to provide oxygen to at least 4 different patients at around 5 liters per minute. We also have some basic diagnostic equipment, some beds, and again, it is a permanent structure, which allows us to provide a pretty significant level of care compared to Everest ER. And we even have a kitchen with a nice yak dung heated stove here to keep warm in the evening time. This is actually at the end of the season with the crew from Everest ER, myself, and a couple of friends from home that came out to visit. Meanwhile, Everest ER, the inside of that tent looks like this. And so we see that we have quite a bit different level of resources, much less available. Well, there is electricity. This is powered by a very small solar panel. There's a small bed where this gentleman is sitting on right here. Mentioned really basic medical supplies, but there's no oxygen available up here. Anybody that gets really sick, this kind of acts more like a stabilization point before they're sent down either on a horse, yak, or a helicopter. However, there are many things up at Everest Base Camp which are a little nicer. The increased interest in Everest over the years from climbers and trekkers has brought quite a bit of money to the area. This is a nice place to go for some of the better coffee that you can have in the region. So I would come up and visit and would work a few shifts up in Everest ER. And then also quite a number of interesting people sitting around. This is King and David, who came to visit our tents a couple times. If anyone's seen 14 Peaks, it's a really an interesting place full of interesting people. Despite its lower level of resources, has quite a bit to offer. Now, with all of this increased interest from outsiders and all this money that is poured into the region, we've seen a dramatic increase in the amount of altitude-related illness. This is one of my favorite pictures that I took. This is between Beriche and Lobuche around, this photo is taken around 15,500 feet. There's actually a tourist that was too tired and likely experiencing acute mountain sickness and therefore couldn't walk. So simply paid his guide to put him on top of a horse and continue to take him higher. Meanwhile, there's actually a porter here who was carrying. I actually asked this guy how much that weighed, and he said around 150 pounds worth of gear, hauling that completely by himself, and did that over 2 to 3 days, going from Lukla all the way to Everest Base Camp. So quite a bit of disparity that in and of itself is not good, but also creates increased risk of getting sick and sicker at elevation. And so this is where the Himalayan Rescue Association comes in. The mission of the organization is to provide low or no cost care for the porters and the Nepalis that are working in the region who don't have the means to pay for expensive healthcare or a helicopter ride down to a lower elevation. The organization is also all about providing altitude illness education in order to prevent people from getting sick. So the trail up to Everest Base Camp is dotted with these little signs everywhere that try to educate people about altitude-related illness and advertise some of the educational resources and some of the low-cost care that's available. And so we'll talk about altitude-related illness here as a quick review for people who are not accustomed to or not familiar with this area. But does anybody have any questions about the Himalayan Rescue Association? All right, cool. We'll move on. So it's important to understand altitude, some of the physiology surrounding being at altitude. The elevations that we see in this area are unlike anywhere in the continental United States. While we do have some, high altitude locations in Colorado and Utah, it's really quite a different level in Nepal. And we'll see why here in a subsequent slide. But it's really important to understand, like, why does altitude affect us? Why do we get short of breath? Why do we get sick at altitude? And what it comes down to is not the composition of air, but it's actually simply just the pressure of air. So here at sea level, air that we breathe is around 78% nitrogen, 21% oxygen, and then 1% other gases, which consists of carbon dioxide, water vapor, and some other gases. This is at sea level. When we are at the summit of Everest, the composition of air is still the same. It's still 78% nitrogen, 21% oxygen. So what's different? It's just the pressure. And so when we're at sea level, every breath that we take, we still inhale a constant volume of air, but just the amount of oxygen, essentially oxygen atoms that we're breathing in, is much less when we're at altitude. So what that results in is decreased absorption of oxygen from the environment and a lower amount of oxygen that is dissolved in our blood and bound to hemoglobin. And so this graph actually shows when we put a finger probe on what our expected oxygen saturation may be at different elevations. Here at sea level, with the partial pressure of oxygen being around 160, we should have a normal O2 saturation above 95%. Now, as we go up, this is the elevation in Denver, which is around 5,280 feet. You can see that there's a small drop in the partial pressure of oxygen, getting here to like a higher town, which is at Breckenridge, is at 9,300 feet. The amount of oxygen that we have available in the air is the number of oxygen atoms that are breathed in with each breath are around 69% of what you would breathe in at sea level. That continues to go down here. We're at like Pikes Peak, 14,000, Everest Base Camp, 17.5 or 17.6. That contains, each breath contains about half the amount of oxygen that you would breathe in at sea level. And then the summit of Everest here is around 1/3 the amount of oxygen per breath that you would breathe at sea level. That doesn't mean that's what we're seeing on our fingertip. I think if we take an like we take a finger probe and measure oxygen saturation, in Breckenridge, it's not unusual to see people that are in the 80s to 90s. At base camp, it's not unusual to see 70s to 80s. And even at the summit of Everest, I mean, we're talking 50s to 60s, and people who are otherwise asymptomatic, not short of breath. And this plays a big role in the development of altitude-related illness. And so this is, I took this slide from another presentation that I used to give to some of the residents in Colorado. But this is kind of a trick question, but like which one of these oxygen saturations is normal at 14,000 feet? The answer is they actually both are. And so we actually have quite a bit of variation. One of the more common, we'll call them complaints from people who are visiting the Everest ER and FARJ for that matter, is people will walk in with a probe on their finger and say, hey, like my O2 saturation is in the 60s, thinking that they're having an emergency. And our first question is always, how are you feeling? And if they're feeling okay, we're like, both of these numbers, these are totally fine. These are expected oxygen saturations at that elevation. So what we care about is whether they're experiencing a clinical illness. This is what expected kind of cutoff for what we would expect to be on the lower end of an oxygen of O2 saturation for anybody who's visiting these locations. So around sea level, say we're 95 to 100. If people are at Breckenridge and they're setting 90s or even high 80s, it's not unusual to see that. At Everest Base Camp, most people are walking around in the 70s to low 80s as their resting oxygen saturation. And at the summit of Everest, we're in the 50s. That's not with exertion. That is at rest for people who are asymptomatic and are well acclimatized to their environment. So what are the altitudes that we really care about? Really, 8,200 feet is where we start to see actual risk of illness secondary to the hypoxia of being at higher elevations. This cutoff is higher than most in any real cities in the United States. Living in Denver, it was very common for us to get people that would come into the emergency department suffering from headache and kind of feeling short of breath, and thinking that was due to the altitude. But we don't really see altitude-related illness until we get around 8,200 feet. That's where we actually care about people that are at risk of getting sick. Now, if you remember from that map of the Khumbu Valley, the entire Khumbu Valley is above this elevation. So this is why we care so much about people who are traveling in this area and their risk at getting an altitude-related illness. In general, we want people to ascend less than 1,500 feet per night. That's sleeping elevation, so it is okay for small periods during the day to go higher than this. But as long as the sleeping elevation every night as people ascend is 1,500 feet or less, most people do not get sick. That gives the body enough time to acclimatize and adapt to the environment around them. However, around 20% of people will still experience symptoms despite following these rules. They're usually mild, not usually getting life-threatening illnesses, but it's always a risk when we're traveling above 8,200 feet. And so there are some other altitude-related illnesses that are less common, but these are the main ones that we care about. AMS, or acute mountain sickness, HAPE, high-altitude pulmonary edema, or HACE, high-altitude cerebral edema. And just as a review, I realize probably other people have given lectures about these in your lecture series. Acute mountain sickness is a benign condition that really represents a failure to acclimatize to an elevation. The main symptoms of this are headache, as well as GI symptoms, usually nausea, vomiting, or just decreased appetite. Fatigue and insomnia. This has been, I mean, fatigue is part of the criteria of how we grade different severities of acute mountain sickness, as is dizziness or lightheadedness. Insomnia is technically not a part of the diagnostic criteria anymore, but is still experienced usually by people who are experiencing AMS. And now we treat this. I should sit back up and say we can give medication to prevent AMS in certain people who are susceptible to this, which is usually Diamox or acetazolamide. Both acetazolamide and dexamethasone can be used to treat symptoms when they start. But more important than treatment is to stop the ascent and to not go any higher. Because not only will going higher make these symptoms worse, but it will make the likelihood of developing a life-threatening condition like HAPE or HACE much more likely. Now, we don't have to descend. If people are feeling unwell when they're experiencing just AMS, simply staying put, giving their body time to catch up with their acclimatization is usually enough to get them feeling better. However, if they continue to go up and they experience something like HAPE, they do need to descend. So that's an important difference that AMS has compared to HAPE and HACE. HAPE, or high altitude pulmonary edema, is a life-threatening condition, and it is actually what we see more commonly than I mean, AMS is common in the Khumbu, but HAPE is the most common life-threatening condition that we see. I think in the last season we had 52 patients with HAPE. And these are usually patients that are trying to get up to a higher elevation very quickly, and they're not taking the appropriate time to acclimatize, not listening to their bodies. They usually have AMS as well. It's a different disease process. They're not going to die from their AMS, but they will die from HAPE. And what this is the lungs start to fill with fluid as a response to increased pressure within the pulmonary artery. The symptoms that we see of this typically are a cough that progresses on to being short of breath with exertion, and then finally short of breath at rest. The very, very late finding is actually people coughing out that fluid, that interstitial fluid that's filling their lungs, and it looks like pink frothiness. It's not super common. I've only seen that one time in a patient who was satting in the low 30s upon coming to the clinic. Very, very short of breath. Now, what do we do for this? We do have medications that we can give, like calcium channel blocker called nifedipine, which works okay. But the most important thing to do is actually just to correct the hypoxia by giving them supplemental oxygen. This is a temporizing measure in order to get these that we get just to we can descend these people emergently. This picture here is a porter that had made a run from Lukla to Everest Base Camp in 2.5 days. Delivered his load up there, and then began to feel sick, and did actually manage to come down to our clinic, but arrived at the clinic sitting in the 40s and had oxygen saturation that did improve with supplemental oxygen that we were able to give him here. You can see here that I'm doing an ultrasound on him, and the finding that we're looking for those that are familiar with ultrasound, are pulmonary B-lines. And so these are diffuse confluent pulmonary B-lines. And what that we see is that is a sign of pulmonary edema. These sound waves are is actually an artifact that is made by the sound waves traveling through a fluid-filled lung parenchyma. So this is our main way that we diagnose HAPE in the field. But we can listen to the lungs. We can get a good history that will tell us a lot about what's going on. Fortunately, while ultrasound has become much more portable and very diagnostic, so is X-ray. And this is actually the MIN X-ray that the Himalayan Rescue Association was gifted during the 2024 season. It has allowed us to capture X-rays of not just the lungs, but any kind of orthopedic injury that happens up at altitude. This is one of my medical students from Colorado, who's now an ER resident at Denver Health, who did a rotation up there. And we can get these really amazing X-rays of HAPE that we don't often see, because HAPE usually occurs in a wilderness setting where we don't have X-ray. So we can see these patchy opacities, which are the lung filling up with fluid as a result of the increased pulmonary vascular pressure. So pretty cool stuff. HACE, on the other hand, if HAPE is swelling of the lungs, HACE is swelling of the brain. This is what actually represents the likely is what is due to progression of AMS. The symptoms of AMS are very similar to HACE. We actually define this as AMS plus a secondary symptom, which is a hard neurologic symptoms or signs such as confusion or hallucinations, ataxia or inability to walk in a straight line, or stupor, decreased responsiveness. If anybody looks like they're experiencing acute mountain sickness, some kind of a headache, fatigue, nausea, vomiting, dizziness, but they have one of these, confusion, ataxia, or stupor, then we're very concerned about HACE. It's actually a video of one of our HACE patients walking through the emergency department who'd actually been seen the previous day for AMS, but continued to worsen. I'm not sure how well the videos are coming across on here, but he's has an ataxic gait requiring other people to help him walk. He was actually brought in by his friends because he had been hallucinating at the lodge that he was staying in. So they were concerned he may have gotten into mad honey, but what he actually had was HACE. Treatment for this, we do give dexamethasone to try to decrease brain swelling. But similar to HAPE, what we really need to do is get these people down to a lower elevation as soon as possible. We give them oxygen until we're able to do that. So what does a descent actually look like? How do we get these people down to a lower elevation when we're in this kind of setting? Again, there's a small trail, it's covered in rocks. We have somebody that's experiencing ataxia, or in the case of HAPE, desaturates down to like the low 30s anytime they try to walk. Are these people really going to be able to get down themselves? Probably not. We can't send an ambulance up. So we're typically either going down by horse, yak, or helicopter. And this is that same patient, actually. And this is what a helicopter evacuation actually looks like at that FRHA. So we don't have any dedicated life flight. So gurney, with no medical helicopter. These are actually these are actually just commercial helicopters, which have taken their gear from Everest Base Camp and are on the way down, and will graciously transport one of our very sick patients down. And they've typically just strapped them into one of these seats and try to get them down as soon as possible. And these helicopters provide a very important service in the area for these really sick patients.
Is your thing still going on, or?
Yeah, it's recorded in my house.
So evacuating patients looks quite a bit different than it does in the United States. Now, what do we do when we can't evacuate? Like, the weather is horrible up there. We get lots of there's quite a bit of right number of storms that roll in, particularly in the early season and late seasons, very cloudy with poor visibility. So we do encounter a lot of situations where we can't immediately descend someone. So in these cases, we actually will simulate descent by using a gamma or gamma off bag. This is a portable hyperbaric chamber that is able to drop our patients simulate a drop in elevation of a couple thousand feet. And these are bags that roll up really nicely and are very portable. And we can roll one of these out and put our patient directly inside, zip them up, and it has this little pedal that we pump. It takes that once it's fully pumped up, it takes about one pump every 2 to 3 seconds to actually keep it pressurized. But it's very cool and allows us to actually see a significant improvement in our patient's clinical status as well as their oxygen saturation just in a matter of minutes from going in one of these bags. And one of the cool things to do is to put somebody in there and have them hold up their oxygen saturation and watch as it's literally rising from them being inside of this bag. And there's no extra oxygen that we add to this. It's just an increase in ambient air pressure. And so that's kind of the specific altitude related conditions that we care for up there. They're very, very common. We saw in my most recent season up there around 50 cases of HAPE, over 100 of acute mountain sickness, or AMS, but only around 5 or 6 cases of HACE. So HAPE is much more common and is the more deadly illness in this area. But of our total season, we saw maybe around 600 plus patients. So most of our patients are coming in with unrelated conditions. And there are a number of different environmental conditions that we see at this, mostly just due to how remote and how exposed our patients are. In the Khumbu, there's very little dental care. It's very common to get a number of patients coming in requesting dental extraction. So that's actually part of one of the services that we offer. This is me actually extracting an infected molar for a patient. The Himalayan Rescue Association has us do a day in a dental clinic so that we learn how to extract teeth. And that provides a really important service for especially the porters that are up there and don't have access and can't afford to go see a dentist. The porters are carrying around quite a bit of weight, so it's very common to see orthopedic and musculoskeletal injuries. This was a dislocated finger that I'm pulling back into place here on the right. You can see some of those loads and what they look like. It's pretty insane to see what the large and heavy loads that these porters are taking from Lukla all the way up to Everest Base Camp. We see a lot of orthopedic injuries as a result of them carrying such heavy loads, and oftentimes from having maybe not the best technique. See this head strap here that's used by a lot of the porters to try to help shift the load onto their back. And so we do see a lot of patients with pretty severe and also chronic neck pain and back pain. And then a lot of orthopedic injuries from inadequate footwear. This is a gentleman wearing kind of the old-fashioned gum boots as he navigates these pretty treacherous trails all the way to Everest Base Camp with over 100 pounds of lumber on his back. We see frostbite quite a bit, particularly at nighttime and as we go up higher. This is frostbite here on the fingers. This is another gentleman who had frostbite here on his cheeks and nose from actually being on Everest and coming down during a storm. Part of the acclimatization process, what our bodies do is we actually, as we go higher, we urinate out extra fluid to help assist with that acclimatization as we dump bicarbonate. What that does is it leaves us hemoconcentrated, putting us at increased risk of blood clots or DVT. So this is a gentleman who came in complaining of some calf pain, found on our ultrasound that we did up in Everest ER to have a blood clot. It's a very common problem. This on the left here is chilblains. Many people think this is in getting something like frostbite. But you can say this is a combination of chilblains, which are these little lesions here on the finger, and the Raynaud's phenomenon, which is a vasospasm that happens as the fingers and sometimes toes are exposed to cold temperatures. And probably an overlooked, really common environmental illness that we see up in these areas is exposure to carbon monoxide. A lot of people coming in with headache and kind of vague symptoms. That seems to get better as soon as they leave their lodge that they're staying in. A lot of that can be attributed actually to the use of fuel, particularly to heat, like showers, and exposure to carbon monoxide. So there are a number of environmental hazards up in these areas, many expected, many unexpected. Actually on Everest, again, you see quite a bit of orthopedic trauma. This is one of my favorite pictures that I took here. It's a little hard to tell what's going on. But this is the group of climbers at Everest that had never summited or attempted to summit a mountain before. And so we're learning how to put on crampons for the first time and learning how to use an ice axe for self-arrest. So I kind of sat here and watched them for a little while as they learned how to climb a mountain on the world's highest mountain. So quite a lot of inexperienced climbers that experience a number of orthopedic injuries just due to inexperience alone. It's not always easy to get these folks down. Hopefully, as physicians, we're actually not allowed to step foot into the icefall and onto the mountain, so we rely on the climbing Sherpas and some of the staff to get them down to our tent. This is actually a Russian gentleman who was frustrated with the slow pace of the Khumbu icefall, so attempted to pass another climber on the ladder and goes over the icefall and fell, catching his leg in actually one of the ladder rivets, causing a tib-fib fracture. So they brought him in, we splinted it, and this is him getting onto the helicopter to fly him down. There was no way we were getting him down in any other way. And sometimes our patients are not even human at all. This is also one of my favorite pictures. Sometimes our patients are the local animals that really do not have any veterinary care in the area. This is a baby yak that was attacked by a wolf that lives in the area. This is another yak that actually had mastitis, so it's getting an injection of ceftriaxone by myself. Probably not standing in the best location to do that, right behind his leg, but because these animals are such important beasts of burden for the area, and really, their owners depend upon them to make as much money as possible during the climbing season. We do need to provide care not just for humans, but for the animals of the area. And some of my more entertaining patients come from these kind of experiences. And so lastly, I think we'll just talk really shortly about some of the emerging challenges and needs as we send more and more people to these high altitude and remote locations. And that's specifically, well, mostly I'll try to tie it into healthcare here. What we see in this area is as more people are going up, and what is being overlooked as all this money and investment goes into the climbing economy, is that there's a big lack of any kind of health screening or community outreach. While, as I was kind of showing before, there's around 50,000 trekkers who go up to the area and 500 climbers. The number of Nepalis that work in the area, whether they're Sherpa or they're lowland Nepalis who are coming up to try to make as much money as possible, the access to just routine healthcare is very, very, very limited in this setting. Part of what the Himalayan Rescue Association does is enlists the help of Nepali physicians who not only act as a translator, but these are folks who are very, involved with their communities. A lot of the work that the Himalayan Rescue Association does is specifically providing primary care to these folks who are at, or are very very much disadvantaged and at very high risk of experiencing health outcomes related to like untreated hypertension, the orthopedic trauma that we saw, and so these are really, really important things that the organization's doing. It's not just about providing healthcare to the climbers and trekkers who have the money to just get on a helicopter and leave. These are some of the people. I mean, we always think about the Everest climbers that come from around the world, but the Everest ER and Himalayan Rescue Association shares camp with the trash cleanup service SPTE and the icefall doctors. And so I do a group puja at the beginning of every season. Really cool stuff and really amazing to work with all these folks that are up there. And when it comes to technology, things have made major strides, but we still have a long way to go. Any way that we can take technology that we use in the front country, in an regular emergency department, and make it more portable and resistant to the environmental conditions, the better it is suited for improving our patient outcomes in these settings. So we typically want to look at devices and try to figure out ways that we can make them more miniature, impact resistant, thermal resistant, and reusable. The clinic in Ferice is an 8-day. It's an 8-day voyage from Lukla for any equipment that we get up there, unless it's flown in by helicopter. And so the smaller it is, the more resistant to any kind of impacts, the more resistant it is to multiple freeze-thaw cycles, which happen multiple times a day. And the more times we can use it, the more patients it could benefit from its being there in the first place. And so things like the Butterfly and some of the other, like the GE V-Scan, and how they've adapted ultrasound technology, which used to be these very large boxes, down to just a small little tool that we can bring with us. It's really changed how we can provide healthcare in this area. Another thing, I love these pictures to try to show kind of like how things have progressed just in the last couple of years. Helicopters are everywhere in the Khumbu, primarily involved not really in ferrying humans, but like supplies. And in the 2024 season, they rolled out the use of drones. This specifically is what's referred to as the poop drone. This is actually a bag of literally of human stool inside of a bag, where we would normally have to have a helicopter to try to ferry down garbage from Camp 2. We now have this drone, which can bring up to, I think it's like 25 kilos worth of garbage and human waste off the mountain. And so we do have technology that's becoming much more miniature. It's really changing the way that we do things and making the mountain better and safer for everybody. Although this thing is it is a little unnerving. I took this picture right as the bag of feces like flew over the top of my head, and it's a little uncomfortable feeling. And then other things that we're working on right now. This is actually one of my research projects when I worked up there. Utilizing miniature CPAP and BiPAP technology to treat HAPE and AMS. You can see just a small device like this that we use to bring directly to patients to try to improve their oxygenation. This has the potential to work much better than larger tanks of oxygen, both in terms of its mass, but also its energy usage. So really cool stuff happening. And then we can just see, like in a setting like Everest ER, how if we have to make this less for our entire season, what equipment are we going to use? How valuable is the space and the mass that's associated with that? Pretty valuable. And then lastly, telemedicine and autonomy. This is like something that, when I put the slides together, it's probably already outdated. A couple of years ago, there was no communication apart from satellite phones that was available. This is actually taken a couple of years ago. This is a picture of EverestLink, which is a series of relays, which is actually a giant Wi-Fi antenna that relays all the way down to Lukla, where it then connects to a normal internet line. This is how internet is provided in the area. And you can see that these relays are highly dependent on being properly aligned, but also need to not be covered by snow, which is a big problem in the early season. Now, Starlink is bringing, the ability to do telemedicine to these areas, but it has a long way to go, and it's actually still technically illegal to use in Nepal right now. So there are major barriers still to telemedicine, despite all of the recent developments in the last couple of years in technology. So what do we do with this is we actually have to improve autonomy. How do we allow physicians or healthcare providers to make better decisions and provide resources themselves without depending on outside help through telemedicine or through constantly supplying resources? And so this is the whole reason why we do wilderness medicine training. And it all involves sitting down and looking at your patient and taking a good history and performing a good physical, being familiar with all of our equipment, being familiar with the environmental conditions that we're facing. These are the things that allow for us to do good medicine and deliver good outcomes for our patients. And this is a video. I'll end this. This is a video of another video of the puja at the beginning of our climbing season, where all of the staff, in Tibetan Buddhist tradition, prayed for the mountain to spare them ahead of the perils that they'll face during the climbing season. All right, and that's all I got. Thank you, guys. If anyone has any questions, feel free to speak up. I've also put my email in there if you're interested in learning more about how to work with the Himalayan Rescue Association, or just want to know more about wilderness or mountain medicine or even space medicine. I'd love to hear from you.
Dr. Strickland, quick question about what do you find is, what's the incidence of waterborne illness or GI issues related to contaminated water up there?
Yeah, it's a good question. Clean water is very difficult to come by. Mostly that is from human contamination by people literally, urinating or defecating into the glacier. We really rely on just disinfection. Like my personal usage was with a SteriPen. The water is actually very clear. It comes right out of the glacier, and so one of the barriers to using UV sterilization is you have to have the clear water, but that glacier water is delicious and clear. It just has a number of viruses in it, which will get you very sick. And diarrheal illnesses are a major problem in base camp.
Okay, thanks. And also, I guess on the trekkers coming up.
Yeah. For the trekkers, most of them, because the towns as they go up are so well supplied, most of them are drinking bottled water. But that is a problem. There's a lot of education that goes into like telling these folks like, hey, do not drink any of the water out of the streams. Don't trust water, unless you can verify that it's like a sealed bottle. That and we do see a lot of people with travelers diarrhea and like norovirus.
Okay, thanks.
Of course.
Dr. Strickland, when you had the photo of the helicopter evacuation of the gentleman who had HACE, does anyone accompany the patient on those, or is it just the pilot and the patient who flies down?
we have the ability to travel with them in those situations, but one of the problems is that it's very difficult for us to get back to the clinic if we were to go with them. The helicopter is not under any obligation to return us, so we try to avoid that whenever possible. Luckily, in my experience with when we pre-oxygenate patients, where we get them on the oxygen like a mask, we essentially walk them out to the helicopter, take the mask off, and we're talking about them getting down to a lower elevation in about 10 to 15 minutes. It's usually good enough, and the helicopter will drop them off essentially at a hospital upon getting to a lower elevation, and we're all on WhatsApp, so we'll text them ahead of time that we're about to send them a patient, but they'll be unaccompanied while they're in the helicopter.
Thank you. Excellent presentation.
Thank you.
Thank you so much. This was so cool. You talked about like one of the main goals being providing free care for locals. Is it like mainly funded by philanthropy or is it from charging like people that are attempting the climb and get injured or people that are at base camp?
Yeah, it's both. They do really rely on external donations. They have a couple of corporate sponsors that have helped them like build the new clinic. And so that's all very important. But they do ask that, anybody that has the means and kind of by that definition, if you're a foreign trucker in that area, you have the means. And so they ask them to pay. Many people have travel insurance, and so the organization's very good at billing like insurance for that. But yeah, sometimes we do get in a little bit of some tricky situations where trekkers don't want to pay. But it is an important part of keeping the clinic running, for sure.
Cool. Thank you so much.
Now, when you were up there, were you at the Wanju Sherpa Hospital now, or were you at?
No, the Wangchu Sherpa Hospital is like, I mean, it's technically not in the Khumbu. It's actually further down than Lukla. That is a fully functional hospital that is there for the locals. It's a little different scope of care than what we're providing up in like Ferry Che and Everest Base Camp. There is a semi-definitive care/hospital up there called the Kunde Hospital. But yeah, the Wangshu Sherpa Hospital is very well equipped and has permanent staffing year round.
Great, thanks.
Thank you so much, Dr. Strickland. If anyone has last minute questions, feel free, but thanks everyone for joining us.
Yeah, thank you.